Hey, good evening. My name is Andrew Hurd. I'm a pediatric neurologist at Texas Child Neurology in Plano, Texas, and I've been asked to, and I have a particular interest in headache, and I've been asked to talk to y'all basically about headache in the setting of a Chiari malformation, especially in children and adolescents. So here we go. I wanted to start this off fairly quickly with a kind of a typical case that I would see in my practice. It's fairly basic. And we'll just say it's a 12-year-old boy or girl, doesn't matter, who presents for frequent headaches. This child's pain is located primarily in the forehead, occasionally in the back of the head. It's a pounding sensation. There's pain that worsens with lights and loud noises. We call that photo and phonophobia. Those worsen the headaches. Occasionally the child has vomiting, and they've worsened over the past 6 months to where they're occurring nearly every other day. So this is almost half of the patients I see in my practice. So we basically diagnose this kid as having a migraine. Simple as that. However, after talking with the family and after a much reasonable parental concern, and given the fact that his headaches were worsening, ultimately we ended up getting an MRI, and findings suggested something called a Chiari malformation. And ultimately the question is what does this mean and what do we do now for the neurologist and the parents? So briefly, this has already been talked about, obviously, by people that know a lot more, but Chiari malformation is the downward displacement of the cerebellar tonsils, roughly 5 millimeters, although, that's not completely accurate, through the foramen magnum. As you can see in the picture, the yellow line being roughly where the foramen magnum is, and the arrows pointing to the cerebellar tonsil. So, it's not really known how much it's seen, roughly about 1% of the general population. Headache is the most prevalent symptom reported, but symptoms of Chiari malformation are relatively poorly understood, exactly what the symptoms are, and especially particularly in children. I think early on they thought symptoms predominantly started in the 20s and 30s of age. However, of course, there's been increased recognition of cases in children likely related to the ease of getting MRIs. It was thought that symptoms were a little bit different in kids less than 6 of age compared to kids greater than 6 of age. And this is important as it relates to how we treat headache. But there's a number of symptoms that I kind of listed below here. I won't read them all. Again, symptoms for kids 6 and older are thought to more resemble symptoms seen in adults, with headache being the most common, but also with neck pain, sort of dizziness, vertigo, sensory changes in the extremities, poor coordination, lightheadedness or syncope, sleep apnea. And this is important just to kind of say this, is that the symptoms can be divided into 3 main sort of groups of symptoms. There's brainstem symptoms. The brainstem's involved in a lot of vital functions, such as breathing, might have breathing irregularities, eye movement abnormalities, of course spinal cord dysfunction, either due to direct compression or a Syringomyelia. It might pose some motor or sensory losses, and cerebellar syndrome, the cerebellum being involved in coordination, so may have coordination problems, also a number of other sort of issues. And so now I'm going to go on to exactly kind of what I've been asked to talk about, and that's headache in the setting of Chiari malformation. It, again, is the most common symptom. Frequency of adults with Chiari is not completely well understood. It's reported anywhere from 30 to 80%. The frequency of headache in children with Chiari ranges anywhere from 15 to 75%. The headache associated with Chiari is not very well defined, and it's also kind of been reported by a lot of people, all these different types of headaches or qualities of headaches. They're not completely well understood. This gentleman, I believe, is valsalving, and so Valsalva being bearing down or kind of basically increasing pressure, intracranial pressure, as if he's having a bowel movement. But, the headache attributed to Chiari is described predominantly as being located in the back of the head or neck. That's brief in duration, triggered by coughing or that Valsalva physical activity. There's little doubt that a headache like this is directly attributed to the Chiari. And there's little doubt about that. The International Headache Society comes up with a bunch of sort of diagnostic criteria for all the different sort of headache syndromes that exist, and they diagnosed headache associated with Chiari as such. You need sort of 2 of the 3 following numbered points. The first one being either one or both of the following. You need a headache and you need a Chiari, basically, is what that says. Oh, and your headache might have resolved with a successful treatment or basically surgery of the Chiari. You can also, or at least have one of the following triggered by cough or Valsalva, located in the back of the head, upper neck, or lasting less than 5 minutes, short in duration. And you might have, and most of the times you typically, when you have this type of headache, you have other symptoms, and going back to those other symptoms being brainstem symptoms, cerebellar symptoms, or spinal cord symptoms. So what is the cause of this headache? It's basically unclear. A lot of theories have been proposed. It's thought, perhaps that, through coughing, Valsalva, you're increasing pressure, pushing that Chiari down even further, causing compression of sensory nerves or nerve roots, causing basically perception of pain. Also thought that perhaps we're obstructing cerebral spinal fluid, the fluid that our brain is sitting in, floating in. We're obstructing that fluid temporarily, I guess, increasing pressure, causing pain. Dr. Hager had talked briefly about this, but ultimately this is a Chiari, but you do have to consider other things when you have a headache, as well as imaging findings that might suggest a Chiari with a tonsillar herniation. You can have, for instance, low pressure headaches when you have a leak. You're causing intracranial hypotension. The brain will start sagging, perhaps, causing tonsillar herniation. This headache is generally different than headache attributed to Chiari. This is generally relieved by lying down. Valsalva improves the headache. Exertion usually improves the headache. In these cases, you generally have other MRI findings as well, so it's not terribly difficult. Now I'm going to get more into where some of the controversy lies on the debate really lies on my end. And first thing I need to do is tell you kind of basically about primary headache disorders. Headache in kids is a very common complaint. Prevalence of headache increases throughout childhood. It's been said that up to 75% of children have reported some sort of significant headache by the age of 15 years. What the definition of significant is, I'm not entirely sure, but primary headaches basically are migraine and tension headaches, a number of other ones, but we'll limit it to that for this talk. But they are generally thought to not be the result of another medical condition. Overall prevalence of pediatric migraine is about 7%, 10% in girls, 5% in boys, and prevalence of tension-type headaches is anywhere from about 1 to 24%. I honestly think both of those should be higher, but migraines, like our case had, characteristics are as such. You can have an aura or without aura. Aura usually includes some sort of symptom that precedes the headache, usually visual. But most headaches, especially in kids, do not have aura. Pain in adults is usually one-sided, around the eyes, behind the eyes, and the temples. It's thought to be pulsatile, pounding. Pain in kids is generally more up in the forehead. Again, you need light and sound. You probably have light and sound sensitivity, nausea, vomiting. It worsens with movement, can be anywhere from mild, but a lot more often associated with severe pain. Tension headaches aren't as well defined. Kind of thought of the stress headache. That's often described as this pressure or band-like sensation around the head. Can meet maybe a criteria or two of migraine, but ultimately does not meet criteria for migraine. Pain's thought to be more mild to moderate, not severe like with migraine. Generally worsens throughout the day. So the ease of obtaining an MRI has led to a lot more sort of incidental findings of Chiari, especially in kids. And given the high amount of migraine intention, the high prevalence of migraine intention type headaches or primary headaches in kids, it's likely that migraine intention headaches coexist with Chiari. And then some question is raised that are these two related to each other? And then how do we go about treating them? There's been relatively few studies but have somewhat demonstrated a relatively high frequency of migraine or tension headaches in the setting of a Chiari malformation. In studies pertaining to Chiari malformation, it's thought that most identified cases were found in patients who underwent imaging for other symptoms such as seizures, developmental delay, and other disorders that we do not typically associate with the Chiari malformation. And so ultimately it's kind of just basically thought in simple terms that they can exist and not cause any symptoms. And so this might suggest that a significant amount of patients with migraines or tension headaches, that these headaches are not associated with their Chiari malformation. I'm going to kind of get a little bit off topic and talk about kind of when should we image for headache. Of course, I see all these patients in my practice for headache, and parents most of the times are hoping to get some sort of imaging. And so it's hard to decide who gets imaged and who doesn't. You know, obviously we're looking for red flags. Some of these are very nonspecific. Some of these are very worrisome. You know, the headaches that wake the child up from sleep or occur early in the morning is a little bit worrisome, although can be nonspecific. Early morning vomiting without nausea, worsening headaches, increased frequency of headaches. That's pretty much every one of my patients. But personality changes, complaints of the worst headache ever, fever, stiff neck, headaches associated with neurologic symptoms, headache following. It says injuries or trauma, more significant injuries or trauma, not just your basic sort of mild brain trauma, concussion. Problems with imaging. In patients with migraine or tension headache, imaging is not necessarily needed. You very well could have some incidental findings like an arachnoid cyst or perhaps in a lot of these cases Chiari. And findings rarely will change the outcomes or management, and this may lead to unnecessary anxiety and perhaps even unnecessary interventions. And so now I'll kind of go back to being on task and talking about Chiari specifically. Do we need surgery for headaches, any type of headache really associated with Chiari? It depends on the signs and the symptoms. I don't want to talk too much about this, but surgical treatment of Chiari I malformation without any symptoms, there's a little controversy, but pretty much for the most part, most everyone advises watching or surveillance. Now we get into those patients with headache and Chiari malformations, and what I was reading is basically you could classify them into three groups. Headache being the only symptom, headache being the only symptom, but you might have imaging findings such as Syringomyelia, or headache with other neurologic symptoms. And so management of the first two groups is controversial. You know, it's thought that as we get older, malformation might even resolve on its own. For the first group, I think most would say, you know, the headache-only group, most would say surveillance, watching. The second group, there's a little more controversy. I think many would suggest watching, but I get the impression that most would say that we need to surgically intervene in those cases. And then those in the third group that have headaches and have other neurologic symptoms associated with Chiari, then they need surgery. I was reading a little bit about those that have chronic headache, like chronic tension headache, chronic migraine, chronic daily headache. not necessarily a headache that you would classically attribute to the Chiari. And those people that did somehow end up undergoing decompression, that there was some success in resolution of their headaches, thought to be up to 60%. However, this is ultimately considered to be sort of a last option in the case, as surgery does pose its risks. So this is kind of a lot of where I come into play, sort of medical management. When is surgery not needed? And so there's all kinds of medicines that we could prescribe, and I'm talking predominantly in just children. There are more newer medicines that have been developed, particularly for treatment of headaches, although we're not able to really prescribe them for kids at this time. But there's all kinds of medicines, beta blockers, antihistamines, different antidepressants or anti-seizure medicines. You know, generally in the pediatric population, we're kind of limiting it to sort of these three meds: antihistamines like ciprofloxacin, my young kids. Amitriptyline is probably my most prescribed medicine, or anti-seizure medications like Topamax, topiramate, or even valproic acid. I do want to draw attention that lately, especially for my more chronic headaches, I bring up the point that headaches are very stressful. And stress worsens headaches, which worsens stress, which worsens headaches, and you often get into this vicious cycle. And lately, I've been more inclined to prescribe, more traditional SSRIs, as there's some evidence to say it helps with headaches, and I generally have a lot of success with that as well, especially in my adolescents. As needed medications agree that we avoid opioids at pretty much all costs. But obviously over-the-counter medicines like NSAIDs, but also some prescription medicines, triptans, which are migraine medicines and nothing else. They can be oral, they can be nasal, they can be injectables, Tylenol, steroids are often given, DHE, and there's a number of other medicines that we can give. This is an example of a nasal injectable triptan that we could possibly give. I mean, we're even doing Botox for chronic migraine that we've even started doing in our clinic right now. And it's thought it's FDA approved, actually the only FDA approved treatment for chronic migraine in adults, and we can often do it in kids as well. And even though it's 31 injections, it's fairly tolerable after they've done their first one. They tend to not be scared of it the second time. You can even do nerve blocks. Some kids that have chronic headaches, they tend to get something called allodynia, or basically tender nerves in the back of their head, so they report a posterior headache. We can inject a local anesthetic into that site, kind of turn the nerve off for a little bit, hope that it comes back online, less tender, and that can often help as well. There's even a lot of non-medical treatments. These are kind of odd-looking things that you could do, like one on the left is a cephaly device. It delivers a sort of this impulse, this signal that is used to prevent headaches and even treat headaches. The one in the middle actually is called the e-Neura. It delivers an electromagnetic pulse through the head that is actually quite the rush if you've ever done it to yourself. And then the last one is this kind of external vagal nerve stimulator that was originally developed for like cluster headaches in adults, but you could even use it for chronic headaches as well. There's been a lot of debate as to whether or not medical management of headaches even works in kids. I truly believe that it does in certain cases, but ultimately the thing that has been proven in kids is addressing the psychological issues, and that particularly is cognitive behavioral therapy, biofeedback. This child's undergoing some sort of biofeedback where he's training basically his brain to lessen his pain. I don't know if that's particularly the case, but it can be used that way. And there's a lot of other things, acupuncture, meditation, and those kinds of things. But ultimately, I think, and I really stress psychology with my kids with headache, because I think that's probably, especially in kids, one of the biggest contributing factors. And so I agree. You have to acknowledge that their pain is real, but you also have to try to teach them how there is a strong psychological component to their symptoms. So kind of just going back to our case, the patient was being diagnosed with migraine, and we basically said his or her in this case, but symptoms were thought to be incidental. We treated him with amitriptyline, and they had significant improvement over time to headache being only about 1 to 3 times per month. And so, in conclusion, again, headache is the most commonly reported symptom when there is a Chiari malformation. Pain is usually in the back of the head, neck, that are brief and provoked by cough, valsalva, are thought to be distinctive of headaches due directly to Chiari malformation. Primary headache disorders can also exist with Chiari malformations, but for the most part are not thought to be related. There is really no set guideline for the management of patients with Chiari I and headaches. And it's just ultimately, it's very important to consider medical management over surgery any chance you can. And so ultimately, I just want to thank you all. Those are my 2 boys. And that's it, really. So thank you.